Okay, good evening. So I was asked to actually provide some case studies of Lyme, and also, as mentioned, we're not always talking about Lyme, we're also talking about some of the co-infections. So what I'll do is, before I do that, I'll just kind of give my little summary, just to re-emphasize some of the points that have been made by Zara. So, all right, so as always, how do I move my slides now? Okay, and being computer illiterate, my slides are not moving here.
Double click, Jack.
Okay, I done that.
Try again.
Okay. So I have my trusty assistant coming here. So just okay, don't okay. So what am I pressing? All right.
Just down, and that's fine.
Okay, so here we go. So just to summarize once again, the antibody tests are not 100%. Just like with COVID, not 100%. Keep an antibody test for the rest of their life. And these are just three of the studies that we refer to, talking about the sensitivity of the ELISA test that's currently used. So varies between 30% up to 97%, depending upon the population. Next issue is ticks frequently go unrecognized. They're the size of a sesame seed. And one study found that only 14% of patients recalled having a tick at the site of their rash. And then, as mentioned, the rash is not always there. And this is a number of publications talking about the EM rash. It may be present, but it could be less than 50%. And it may be an atypical rash. It's not always the classic bullseye rash. And then the final issue is that we talk about the treatment of Lyme disease and the guidelines. I tend to treat patients, not guidelines. So not every patient responds to 7 days of antibiotics for cellulitis. Sometimes patients need 14 days, 21 days, 28 days. Not 100% of people respond to the treatment. And up until recently, the guidelines in the USA said 2 weeks of antibiotics. And if you're still sick after 2 weeks, it's post-treatment Lyme disease syndrome, even though you're still sick. And the reality is, from all the studies, short-term antibiotics will fail in a certain percentage of patients, especially those with longer standing disease, which makes it important to catch it early. And I think that's a really important message. I'll be talking about some more late stage disease in the case studies here, but I think the critical part is early recognition, based on the history, based on the rash if it's there, and based on symptoms following a rash in the right scenario. That is guidelines to start treatment. And if you treat early, people will do better. If you treat later, it's more complex. And there's a couple of different guidelines that are available. The American guidelines, which most infectious disease doctors belong to, Infectious Disease Society of America, and the private group of doctors that have managed most of the patients, because historically patients have gone to private doctors because they're often still sick and they're not getting the care that they feel is necessary. And this is called the International Lyme Association Disease Society. And I'll just mention just a couple of things. Is there such a thing as chronic Lyme? The Irish guidelines, draft guidelines 2018, said even if you don't treat Lyme, it just spontaneously disappears, just like syphilis spontaneously disappears, but it doesn't disappear. IDSA states that most infections are cured after 2 to 3 weeks of antibiotics. And if you're still sick after 2 to 3 weeks, it's post-infectious. It may not be. ILAD states that you should treat patients, not the guidelines, and many patients get better with longer courses of antibiotics. Critically, if you catch the bite early before dissemination, probably shorter courses treat adequately. The longer it's in your system, the more difficult it is to treat. And even with treatment, not everybody 100% recover. And there's a debate as to why that is. Is there still residual infection? Is it post-infectious? since we don't have PCR diagnosis, it's a subject for debate, and we'll discuss that later down the way. So, as I said, if it's acute, short course of antibiotics probably work much of the time, early diagnosis, but some patients require longer treatment. If it's chronic, many studies, many studies have been done, including studies on Lyme arthritis, that Lyme arthritis needs longer courses of antibiotics. And sometimes there's other infections besides Lyme, and sometimes you need more than one antibiotic to target both Lyme and the other co-infections. And this is just a debate. IDSA, there's no convincing biological evidence for the existence of symptomatic B. burgdorferi infection among patients after receipt of recommended treatment. 2 weeks of antibiotics, everyone's cured. And that's not really the situation from a clinical perspective. And this is data put together by ILADS, which you all can kind of review at your own convenience. You'll be provided this information later that show that there is evidence of persistence of Borrelia in human models, even after the standard treatment. So I'll just go through some of the cases now that I have, just whirlwind tour. This is a simple one, a 29-year-old Irish man from North Tipperary. He was studying at the National University of Ireland in Maynooth. He had the onset of flu, aches, pains all over. He noticed a large rash on his back when he was taking a shower. He noticed it in the mirror. So he was unwell, went to the hospital where I worked, the matter emergency room. He was seen by the infectious disease consultant, actually a junior consultant I trained. And she said it couldn't be Lyme because the rash that he had in his back was too big. And he was discharged from the emergency room with his aches and pains and his big rash, too big to be Lyme. And he was sent to outpatient dermatology and rheumatology. He was seen by the dermatologist and rheumatologist, who are actually both colleagues of mine, and he was seen in private consultation in the next week. And they both assessed, this looked like Lyme disease, it sounds like Lyme disease, and sent the patient back to the mater emergency room. I received a call from one of my friends, an AMU consultant called Kate, and she said, Jack, we have a dilemma. The ID team says this is not Lyme, but both dermatology and rheumatology think it is Lyme. So on the phone, I kind of knew of this case because I'd been told about it by one of the junior registrars. And I said, why did you send the patient home? But anyway, the patient did come back. I told him, do the Lyme blood test since he's there, start on doxycycline for 1 month and bring back to my public clinic at the mater. And sure enough, he returned 1 month later. All of his joint pains were gone. His fever was gone. His rash was gone. Interestingly, his Lyme test was positive. He was only 4 or 6 weeks down the way. Sometimes the Lyme test doesn't go positive, but he needed to be treated anyway. It was confirmed by the UK, Porton Downs. So his standard Lyme test was positive. And I actually did have further discussion with my junior ID consultant, hoping we could bring her on board to have a better understanding of Lyme disease. She said the rash was too big. He didn't see a tick. And then the conversation didn't go well. She didn't want to discuss it. But the point is the patient was cured of Lyme disease. It was caught early, despite initial infectious disease input, not because of the input. And my point of this is that it's good that he's cured, but it's very hard for GPs to catch on when I think a lot of the messages they're getting from consultants is there's a lot of missed messages, and lack of skill, understanding, really interest in this disease. So this is just case number 1. Case number 2, and this is just I don't even know the outcome of this individual, but I just saw this fellow this last week. He came over from Scotland to see me in Ireland. He's a 55-year-old Scottish cyclist. He's an outdoorsman, goes all over Europe biking, and he's been doing it for years and years. He had the sudden onset of left elbow pain, followed by abdominal pain, sweats, headache, numbness, migratory pain in the neck, knees, tinnitus, sleep problems. He never recalled a bite or a rash. He'd never heard of Lyme disease. The GP didn't entertain Lyme disease. He's been going back and forth for 2 years to the hospital with repeated GP visits, And eventually he did kind of cop on through patient groups and other information to do to do a Lyme test, and the German Lyme test was positive, and his Scottish Lyme test was negative. He then went to see the ID consultant in Edinburgh, and he basically, the Scottish fellow said to me this week, I gave them my symptoms, but they were very reluctant to act upon the Armin tests, although they did give me 21 days of doxycycline, and actually he slightly improved. His knee pain got better, but his abdominal pain and the migratory arthritis moving around his body did not improve. I've just started him on treatment this week. He's been sick for 2 years. I'll give you an update down the way. But I think the message really simply is that, I mean, this is a fellow that should know about Lyme disease, given his, ongoing exposure as a cyclist and an outdoorsman. And we need to do a better job of getting the information out there to individuals like this. Case number 3 is an Irish case. An individual who became suddenly unwell 18 months ago with a facial palsy, a headache, and muscle weakness. Now, I had a recent patient with a facial palsy down in Cork, and the GP said, Lyme doesn't cause facial palsy. It's caused by Bell's palsy. It's caused by Bell's. Well, and the patient got nowhere when she tried to explain that one of the clinical manifestations of Lyme disease is Bell's palsy. So Bell's palsy is caused by multiple different infections. It can be a virus, it can be a bacteria. If you're in Africa, it can be HIV, it could be VZV, it could be zoster, it could be herpes virus, but it also can be Lyme disease. So anyway, this patient was referred in by the GP, and the GP's letter said, I'm very concerned she has Lyme disease. The initial Lyme test is negative. She's been sick for 1 year. I'm considering the diagnosis of fibromyalgia. Well, I don't believe in the diagnosis of fibromyalgia because I see fibromyalgia as a series of signs and symptoms that have to have been triggered by something. But anyway, this individual had 18 months of headache, facial palsy, bad fatigue, overheating, unable to move the left lower limb, diagnosed with an underactive thyroid, a deviated septum by ENT, went to see the ENT because of the palsy. They discounted the German tests because the Irish tests were negative. And they said, this is not Lyme disease. As stated, the Irish Lyme test was negative. But based on the German test, the GP did start doxycycline, and there was some improvement. So I saw the patient, a number of months later, a year or more into the symptomatology. The presentation was headaches, fever, sweat, facial palsy type pain, left leg pain, interesting on bloods, had low lymphocytes, high TSH, normal T4. The German tests were 5+ for Borrelia, 2+ for anaplasma. Anaplasma is another infection you get from a tick bite. The ticks in Ireland are carrying Borrelia, anaplasma, rickettsia, and babesia. Studies done in the vet clinic at UCD, and likely ticks don't just bite animals, they bite humans as well. At this stage, I started on a combination of treatment because it had been going on for years at this stage. And at this stage, I see this as not just as a simple infection. I see it as an infection with multiple different bacteria, an infection that's triggered kind of a cascade of inflammation and autoimmunity. So my approach at this stage, a more complex case, was to start low-dose naltrexone, which has anti-inflammatory immune modulatory effect, a series of supplements, and combination antibiotics. And when I saw this patient back at 2 months, energy back to 70%, headache mild, the leg was better, and 3 months more treatment, the patient was completely cured. And I'm not here to say that you all should be treating. We have the nice guidelines, but my opinion is based on, these are complex cases at this stage, and I treated the patient with antibiotics, not Neurontin or pain pain control medications. I treated with combination antibiotics, and this patient was cured within a period of 3-4 months, having been chronically unwell for 2 years. Another case, Irish case number 4, a 38-year-old Kerry woman with 2 years of multiple symptoms. She didn't remember the tick bite. She had the onset of pain, paresthesias, facial pain, anxiety, panic attacks, shaking. The Lyme serology was reported as positive equivocal, read as a false positive, interestingly. She was given 2 weeks of doxycycline 2 years down the way, didn't get better, did then go to get the German test, was positive for Borrelia, chlamydia, pneumonia, had low lymphocytes, was started on a combination of antibiotics, the LDN, and actually 2 years into her symptoms, within 2 months of combination antibiotics, she was much better, and she had total resolution of all of her symptoms and back to the way she was 2 years before within 5 months of combination antibiotics. Case number 5 is a school teacher, 35-year-old school teacher from Mayo, the West Coast. She noticed a mark on her right leg in May 2019. She then was followed by neck, shoulder pain, flu, fatigue, night sweats, poor sleep. She had to take time off work. She was very unwell. The GP considered Lyme, but didn't act on the mark that she saw in her right leg with the symptoms following. Repeated the Lyme test 2 different times, but declined to give treatment because the Lyme test was negative. She went to see a second GP who agreed to give a short course of doxycycline 2 months later. And this is the rash that she took a picture of. So she actually slightly improved with the doxycycline, but her symptoms improved. The rash that she had originally had disappeared, but then it recorded in the exact same location as before. She was told by the GP, the first one, you've been tested for Lyme, you don't have it. She then went to see a dermatologist who saw the rash and says, you don't have Lyme, declined to biopsy. She then was, this is months and months down the way, ended up in hospital 2021, debilitating fatigue, muscle aches, poor concentration. She had scans done from head to toe, all results were negative. She was seen by a university hospital ID consultant 4 weeks before I saw her. And the consultant says, forget about Lyme, go to your GP and get a prescription of 6 months of antidepressants. Refused to look at the test that she'd got done, the German test for Lyme disease. My evaluation then, seeing her symptoms were freezing cold, poor sleep, anxiety, occasional palpitations, poor concentration, muscle aches, exhaustion, and as I said, occasional palpitations. All of her bloods was essentially normal. The German tests were positive for Borrelia, Ig antibody for mycoplasma. She didn't need any of those tests to be treated, as far as I'm concerned. Pathognomonic, the rash and symptoms meant she had Lyme disease. But I started on, at this stage, years down the road, on combination antibiotics, low-dose naltrexone supplements, and she had total resolution of symptoms over treatment during a 5-month period. Case number 6, and this is actually published by one of my medical students, Ross Murtagh, and put together, and the references there. But it's persistent Borrelia infection in response to antibiotic therapy, a clinical case study in recent review of the literature. And this case report describes an individual clinically diagnosed with Lyme disease who initially responded to standard treatment and relapsed when antibiotics were discontinued. And I just like to say that in my practice of infectious disease, if I treat people for an infection and they relapse when I stop the antibiotics, I treat the patient, not the guidelines, because if they responded to the antibiotics, antibiotics work against bacteria, so we must be targeting something right. And my simple conclusion is we just didn't treat long enough. So I've repeated this before. I have patients with lymphedema of the leg. They get a cellulitis. It takes 4 weeks of antibiotics to treat them. Other patients who have skinny legs and good circulation, 7 to 10 days of antibiotics, or even less for cellulitis does the job. But anyway, this case was actually a 56 Irish physiotherapist who actually lives down the road from me in Clontarf, the other side of Dublin Bay. And he'd been in upstate New York, bitten by a tick. 1 week later, he had an expanding rash with non-specific systemic symptoms. The American GP actually gave him doxycycline BD for 2 weeks. He got better. However, 4 weeks later, symptoms returned. He was seen by the Irish infectious disease specialist who said he didn't have a Lyme because his test was negative. This was a private consultation. The patient insisted on getting treatment. So since it was private, the infectious disease doctor gave him 4 weeks of doxycycline. He actually didn't respond to this. Over the period of the next year, as a physiotherapist, he had to reduce his work by 70%. He then had a repeat test done by the GP, which was positive for a test that's used as a surrogate, both in the UK and Ireland, called the C6 peptide, which was positive. He was told it was a false positive. He then had the German test done, the Tick-Plex Plus test that was done, and it was positive. So his symptoms when he saw me were 1 year duration, including severe fatigue, abdominal pain, joint pain, muscle pain, cramps, neck stiffness, cracking, joint stiffness, intense headaches, confusing, difficulty concentrating and reading, speech problems, mood swings, disturbed speech. On my treatment, 2 months of combination antibiotics and the LDN, he returned with almost total resolution of his symptoms and returned to work. Case 7, just another interesting case, a 77-year-old retired GP from the Liverpool area. He actually found a tick on his right ankle. He then developed an ECM rash and systemic symptoms with energy problems, joint pain. As you know, the bacteria disseminate from the skin through the bloodstream to every tissue of the body. He received 2 weeks of antibiotics, which might not have been enough, but he did get resolution of his symptoms. Interestingly, though, 2 years later, the exact same symptoms come back, and he developed a rash, an ECM rash, in the exact same location in the ankle. He was seen at a university hospital in the Midlands, I won't mention where, and you can actually biopsy the skin lesion and culture for Borrelia, and indeed, culture positive for Borrelia. So 2 years later, same infection coming back again, despite 2 weeks of doxycycline, but he was told he couldn't receive further treatment because he'd already received his treatment according to the NICE guidelines. So this is a few years ago. The guidelines back in those days were 2 weeks of doxycycline. They have changed now. They do recommend 3 weeks of doxycycline and then a further 3 weeks of amoxicillin if there's not resolution. But he came over to see me as a GP, and I saw him in consultation, and he'd actually been well for years at that stage. I put him on LDN, a combination of antibiotics. The skin lesion, which I saw was a heaped up lesion, totally resolved, and all of his symptoms resolved within 2 months. And the question is, why was he not retreated? A certain percentage of infections relapse, and retreatment is the norm for these relapse. So he did resolve his infection, and actually, interestingly, on testing, I found not just Borrelia in the standard Lyme test and the standard UK testing, but he also had anaplasma, a second infection that also comes from a tick-borne infection. So in summary, I think what we're told very often, Lyme is easy to diagnose, is easy to treat, and it's quite simple. But in reality, the longer these infections go on, the more complicated they become. And I think we now have experience with another infection that causes chronic persistent symptoms, which is called long COVID. And when they've done scans on people with long COVID, they've done brain biopsies and testing, they do have evidence of residual inflammation years down the way with long COVID. And when they do PET scans, they actually find abnormalities. They've done similar studies in patients with chronic Lyme disease from Johns Hopkins and other places, and patients have persistent brain inflammation and they have abnormal brain scans. We don't have good diagnostics, and people argue whether it's persistent infection or post-infectious inflammation and a damaged immune system. But my observation and my experiences is that in some cases, there is persistent infection that does respond to longer courses of antibiotics. And rather than giving a patient a lifetime diagnosis of fibromyalgia or functional neurological disease or chronic fatigue syndrome, there is persistent infection in some cases. And I think it's a reasonable option to have a suspicion of these infections, and despite negative testing, despite not them seeing a tick, despite not seeing the bullseye rash, and to treat them accordingly. So thank you. I'll stop now, and I think we're open for questions, and I think I've almost finished on time. Thank you.